should be able to give big applications to online only. Okay. Right. Before I start, I'll let everybody sort of introduce themselves. So, obviously, the original order of individual. My name is Jean, and I'm in the chair. For this one.
I'm in John Studies, I'm a new councillor for Curious. Love to see you.
Thank you. Hello, Michael Panton, Group Deputy Chief Exec for Futures Absence.
Good evening, my name is Nisha Kujo and I'm the Group Chief Executive Officer for St George's.
Good afternoon, everyone. My name is Kate Semick. I'm a guest executive, but I'm the Managing Director.
I'm Daniel Holden, leader of the Concerted Group, Hillside Councillor. I'm only here in the service capacity.
My name is Jack Comer. I'm Councillor for the
I'm Councillor Peter McLean.
Very far, social care and everybody, Barry Calls at Social Director of Public Health, attending on behalf of Russell Styles.
Hello, Councillor Tony Rice, Vice Chair, Councillor for Wimbledon Park.
I'm Sarah Goldie. I'm new councillor for Hillside.
Simon McGrath, Councillor for Wimbledon Town and Dundon.
I'm Billy Hayes, Councillor for Gravely, there, and a veteran of having my leg fixed in St George. Thank you very much.
Good evening, everyone. I'm Councillor Brenda Fraser. I'm Councillor for Long.
Evening everyone, Swami Shabaisky, Councillor for Lavender, please.
Richard Seahouse, Democratic Service Officer, covering for the usual scrutiny manager.
Thank you very much. Welcome. Right, if you can start now. Apologies for absence.
Just John Morgan, as I'm aware.
The definition of community.
No.
Minutes of the last meeting. Okay. Read. Are these minutes true?
Yeah.
Also, again, just to be on the same side.
All right.
I've got your thumbs.
I did right.
Thank you. Now we should go on to item 4, which is guest update on the front of you. So if you'd like to make an update, then you have something.
Yeah, so we sent a paper to give a bit of structure to it. I just checked, is Terry wondered about structure? We haven't seen the agenda, but I think you have 2 parts to your agenda. Is that right? Can I just check that and then we can have a
It's really just, it's all of your bit in one.
Yeah.
But in terms of order, I think we're expecting the CQC first. So the 2 forms.
I think it'd be good to take a pause once we get to the end of the CQC.
Yes.
Yes, questions, and then
Yeah, so and I wonder whether we should start with St George's on CQC and then move our way to the question earlier, and then we can pick up within services, people in particular. That's particularly why I'm here to be able to talk to that. And Michelle, we'll pick up maternity somewhere in between. Michelle, our new group director of Individual Officer, also advising the National Task Force.
Okay, so the way I was going to frame this is talk about the CQC well-led, we talked about before here, and then getting in just lightly to the core inspections at St George's, which was in the emergency department, in the surgery and the maternity. But I hand to Michelle to talk about maternity, because we're expecting a sort of follow-up CQC inspection in maternity, and I think it's good to hear you to hear from her directly in regards to that. So just a reminder, we had our CQC well-led in April last year. We got the report around at the back end of October. And I think I shared last time some of the key themes, particularly around culture or concern, or speak up, some issues around, ongoing issues around fair recruitment practices and processes, etc. We went into that in some detail last time. What we have done since I last saw you is, because I think we're very clear that the obvious next thing is to draw up an action plan and to go and help collaborate it. But as an executive team and with the board, we agreed we would not do that because we need to do more exploration ourselves within the organisation and to look at how we work with our staff around doing things differently in a way that we're engaging them, because we had some consistent issues that have been apparent. So in that we've seen section that happened in 2019, so quite embedded entrenched issues that have not been resolved through action plans that happened between then and now. So we spent between November and late February undertaking some further listening events with the St George's. So we did that in a number of ways, led by the division and the site leadership team, but also with members of the executive team joining those listening events. They were done in a range of ways. We ran 33 listening events across the organisation, including Queen Mary's as well, where we brought staff together either in person or in teams, so a mixed way of doing it. We also provided mentor meetings because people don't want to speak up in big groups, or don't feel confident to do that, which is part of the issue. So we used mentor meetings and also QR codes, so people who weren't at those events could also feed back through those events. So, and as I say, we had some wide participation from leadership in the organisation, and we had really wide participation within the organisation, very much how we engage, listen, hear others, and think about what are the next steps and what we need to do differently. And the sort of areas that we sort of picked up, we should obviously align with your feedback from the CPCs, issues around leadership and accountability, culture and psychological safety, communication with the staff voice and how that gets heard, governance and structure, so some confusion around the structure and how it operates and layers of leadership, and workforce development. So we have worked as a site leadership team particularly to sort of explore those a bit more, spent time talking to staff and then coming up with a design, which I'm going to go into a little bit, also leaning into the work we've been doing about people's voices being heard, linked to the staff survey, because a number of the things in the CQC one there very much aligned to staff survey feedback that we're getting, so there's real consistency in triangulation. So they sort of early actions as a site leadership team want to focus on is governance, accountability and process simplification. So how do people get things done and how do you push some of that decision making deeper into the organisation? Because everything, I think it's a big everything gets pulled up to the top of the shop. Visible leadership being really important. So everybody being visible, spending time out on the shop floor. I spend a lot of time on the shop floor and you hear what people are saying, you hear different things to when you're in big groups of people, and it's where you really learn what's going on in the organisation. Creating time for senior leadership teams to be visible, to be out there and not constantly trying to do meetings. Improving communication and staff involvement. So that's been a lot of theme of what we're trying to do along the way. Recognition and celebration of what's good. There's lots of really good things happening at St George's and across the organisation. Recognising and celebrating success and staff contributions. And this whole culture and psychological safety, how people feel safe to speak up, working through lines of accountability and responsibility. And I'll pick up a bit more on that in terms of the alignment with Your Voice, Our Action, which is a corporate programme that work through this design, sort of running right across Sketch. So this sort of key, we've got sort of 4 areas that we should put into a formalised action plan. So I say this is very much on the cultural side. The everything around strategy and the strategy deployment, how people understood the strategy and was it embedded in the organisation. There are other themes that are in the well-led. I think it's important to note that Matt Shaw, who's our new group CEO, who joined the trust in April, so he wanted to take stock a bit about where we're heading with this and making sure we're tackling the right things and how we have engaged with the organisation, which is perfectly reasonable. So we've got sort of 4 areas which we're going to work up in a more formalised action plan. Now the formalised action plan is due to go through our group executive in the next few weeks. So it's not yet available to share, but we will share that with you when that's available. But we're very clear going straight to into action planning is not the answer here. It needs to be only by the but not just by the senior leadership in the organisation. So there are a few four, I guess, buckets, I would call it, that we're sort of focusing on. One is leadership capability. We know that's really critical in terms of how people feel heard and involved in the organisation. If the leadership at any level of the organisation is not working the way it needs to, you'll hear about the middle management issues, and that definitely exists in the NHS, and I think that's more of an issue post-COVID, around people have the skills and ability to lead their staff. So that's a sort of bucket, and we're looking at really making sure that all teams have, and all individuals have one-to-ones, know which team they're in, and that varies across the organisation. I mean, most people do know, but there are some departments where I think people are not clear. Having career conversations with good appraisals. We've got a whole training management program around tiers and starting within the organisation in terms of leadership to make sure we're giving our leaders skills and capability to engage with their staff effectively and make sure that they're operating the way we want them to operate with the right set of values. We're underpinning that with a quality management system, so looking at continuous improvement, which is all of that, and we're rolling out high performing clinical teams. So where we're working closely with about 7 or 8 clinical teams at the moment, whereby the colleagues on the front line pick up issues that are getting in the way of them delivering a good job, and we help them unlock some of that, give them the capabilities to unlock some of those things themselves. Then there's a whole behaviours bucket, and Matt's really keen to go down the civility saves lives route, obviously values around kindness and respect. Make sure people are living the values around that, and we've revised our whole approach around patient and visitor violence, aggression, harassment, racism, because that is a real issue for the organisation, and that has been much more than issue since COVID as well. How you support staff through those experiences and staff feel that you're responding and listening to their needs. Then there's a diversity and inclusion. I think I suppose one to put it better way, looking at our inclusive recruitment, because that's been a constant issue, looking at job descriptions and making sure they're written in a way that's equitable and encouraging people from backgrounds to apply, looking at our recruitment processes and making sure they're fair and equivalent. And actually, since we last met, we appointed 2 members of our executive who are from a BAME background. So we're beginning to change the look of the executive team, and same within my site leadership team, which is really important that staff see the leadership looking like them and reflective of our staff. We have an inclusive board. So we set this up, I think it's probably about 4 months ago, where we sort of advertised the opportunity for people to join, like otherwise known as a shadow board, which is again, membership of that shadow board is very much reflective of the ethnicity of our organisation, and we've got 12 people on our shadow board of our products, makes a bit more sense, an inclusive board. And they're working very closely with our non-execs and with our trust board, and they attend, members of the inclusive board attend our trust board. They run a board the day before our board, and they come feedback and different perspectives around the things discussing on the board table. And that's been up and running for about 3 or 4 months. As executives and site leaders, we all have mentoring and reverse mentoring with members of that inclusive board. That's something we've been doing, that's now in place. Looking around flexible working, because that's an issue where people feel they're not fairly treated across the organisation. How do you create clear, flexible working strategies, and you're implementing that fairly across the organisation? So we spent a lot of time working on that and making sure these simple adjustments in place. And we've got much more strength in our health inequality programme now. We've got 2 health inequalities leads. We've now got a health inequality dashboard where we can dig down into our waiting list and see if there are any groups of people, patients, population who are having slower access to care and treatment. So that's another part of the programme. And then the final bucket is recognition and celebration. That's very much feedback we've got again from the organisation about making sure that we are recognising great practice and people doing things well. We've got a recognition strategy and local to kit. We've got a guest care awards, which we're having for the third year running this year, where we get many hundreds of nominations of staff nominating their colleagues for the great work that they've done, and we've run it a lovely big sort of celebration event, and that's running in September this year. It's normally run around Christmas time. We've pulled it forward this year to make it easier for people to get to it. And then we've got a big thank you week with staff that's happening the week after next, where we're the charity fund both the guest care awards and the big thank you week, where we're sort of making sure everyone spending time thanking the great work that people are doing, but also we've got lots of events going across all of our sites during that week. So they're the sort of 4 areas that we've got strong feedback that we need to respond and work differently. That will get pulled into a sort of overarching CQC well-led action plan. That's the areas I particularly focused on around culture behaviours are the areas we sort of pushed at earlier and had broader engagement about earlier. But we, as I say, we're taking our overall action plan through our big executive in the next 2 to 3 weeks, and then if we need to go to the board. But we had agreed that we would take our time to get that right and engage appropriately to make sure we're not designing something at the top of the shop that doesn't resonate with our staff. So do you want me to move through core inspection and stop at CQC, and then we can take any questions? Would that be helpful? Okay. So we had 3 core inspections at St George's in surgery in the emergency department. So I'll hand over to Michelle for maternity in a moment. In our emergency department, we've had a re-inspection and we have improved on a number of the measures. They've come back and said work operating much better. We had an inadequate state that's meant to require improvement. And we're following through on all the actions that we're asked to follow through on. And we're definitely making positive progress in the emergency department. In surgery, again, we've made real progress around some of the areas that they picked up around surgery. It generally was a better inspection. We were just short of getting them good, but we had we didn't quite make it for surgery. But there's lots of work we're doing around safety, embedding a safety culture. When they came to visit surgery, they recognised all the work that's going on around safety and other events and learning theatres and how we make things like fire safety, etc. But they felt they couldn't see that it being properly embedded at the point they came to do the inspection. They will at some point soon, I would imagine, come back to surgery. We're fairly confident that we're moving to a better direction. But I'm happy to hand over to Michelle to get.
Can we maternity to
maternity CQC, but not. Okay, you can do maternity all in one piece. That's fine. Yeah, that's fine. Yeah. No problem. Yeah. Okay, so let's stop there.
Thank you very much for your comprehensive answers. Because it seems to have answered most of what we wanted to do. And so I'm just wondering how you plan so to keep this going so that you don't fall back. Thank you.
Okay, the microphone seems to make it louder.
No, because
It will a little bit, but
You can you hear me okay?
Yeah.
Okay. So thank you. It's a really good question because we've got to keep this momentum going and it takes quite a lot of time, energy and focus. I think because there's real triangulation between well-led staff surveys is core to what we should be doing and people to do. The work I'm doing with the leadership team for St George's and the divisional leadership teams, who obviously are even closer again to the staff. We have 3 very big divisions at St George's. Is we're committing to a lot of working differently ourselves and thinking about what we do differently around visibility, around making the structures work better, which we're also doing with them as well. So I think we're really committed to keep this work going. We will be held to account by the board, so we will need to be number one. I mean, that's very clear. Culture is number one thing, and if he was here, he would say that. So we will continue this work. I think we're on a really good trajectory, but you're absolutely right. We need to keep it going.
thank you.
Thank you for update. You touched on the actions plan, and so what I would like to know is which actions have been completed, which are in progress, which are slipped, the program. I would like to see as a paper.
Yeah, well, I don't think we're in a position to do that yet. So I think we're in progression of designing the plan. And then the next step is putting that into an action plan with timelines. But we are absolutely progressing all of these things now. They are moving forward. We haven't yet got a plan that shows what happens by when, by whom, but that's the paper that will be going to our executive committee in the next 2 to 3 weeks. In fact, landing some of the completion timeline. These actions are not things that you start finish. They're ongoing cultural changes in the way we operate. So it's not quite as straightforward as saying, right, starting that then and finishing that then. It's just some of this is way of life behaviours and how we operate. So I think we need to think about how we then present that in a plan that gives confidence that we're moving things forward and
We would like to see the progress, so
Yeah.
that you can share with us.
yeah, of course. And then how do we test this at making any difference? I think it's the question we should be asking. And we obviously got staff survey that happens every year, but I don't expect there to be a massive change in the staff survey because it goes out in October and we're really just now embedding some of these things. So, but we would expect over the next 2 to 3 years to see a shift in these areas. We also are doing sort of pulse. I mean, people get sick of surveys. This is part of our problem. People don't really reflect the staff survey. We're trying to do pulse surveys and check-ins. We also run exec question time across the whole group where we sort of seek feedback. I run for St George's the senior leadership briefing. So there are lots of routes in which we get sort of feedback, and the divisions are working much more closely with teams around some of these changes. So we will get checkpoints and feedback along the way. So we're not going to wait for surveys, but I think we will want to see a shift over time. I think that's how we measure success rather than actually meeting on X date.
Yeah, Mike Solway. I understand you can say about process and getting into a routine. So what's your kind of theory or how you do embed things so that they become part of the fans to sort of.
So, I mean, I think you have to get agreement this is the right thing to do, and you need to make that part of your everyday life. So it's easier said than done. One of the things that we are looking to really embed change is continuous improvement and how we work with our teams on the front line around change. We've got some amazing colleagues now who we've recruited into the organisation who have demonstrated they've done that in other organisations. I was at the Royal Free for many years and we embedded continuous improvement in the Royal Free, and that was the thing that shifted the staff survey dial, because until you get staff on the ground feeling they can make changes and address some of the things that make their lives difficult to care for patients, you're never really going to properly deliver that change. So that's going to be a sort of key component.
You mentioned continuous improvement there. That was a bit of a buzzword many years ago, total quality management.
Mm-hmm.
Is that something you're doing now?
Yeah, Jordan.
Let me pick that up because I'm the sponsor for this programme. So yes, effectively, it's a modern version of healthcare total quality management.
Yeah.
So to paint a picture for you, to your point about embedding in the fabric daily routines, by the end of this year, we are hoping that 50 of our wards will have a huddle board on their ward wall where they come together, and it has different things. It has what are we measuring as our access? What are the things that we are frustrated by that we need to fix? What are the things that we've escalated, we're waiting to hear back on, for example? And with the senior nursing and the ward team and their partners, it may be AHP and so on, they're around at least once a week, working their way through those challenges and opportunities. Where are the ideas coming forward? And so we have a thing called, what Peg was alluding to, is called high performing teams. And so we basically upskill in quality management skills and language and process 2 or 3 members of each ward who can then facilitate those discussions when we're not there.
And would they be team lead?
Sometimes, but not always. Yeah.
So just develop that point. I promise I won't leave on. If you're saying there's team leaders in some teams and team leaders not in other teams, how does that? I must make a case for or against it. But how does that deal with the issue of consistency if possible?
Because these take some time to embed. To your point, when does it become part of the fabric? Yeah, we've got to make sure that we get to each team ultimately, and that they are reliably and confidently working their way through this type of process. And we are standing beside them for the first few weeks, and then we recede, and their leadership takes over. And so to get through 50 wards by the end of this year is no mean feat in itself. And when I say wards, I also mean equivalent theatres and so on.
Yeah.
In my experience, they really become quite active when they start solving some of their own issues and they feel in charge of their own destiny. But it takes a while for them to grow their confidence. What data do they need? What are they measuring that's success for that ward, that area? Whose help do they need? What other teams do they need to be working?
Okay.
Yeah, just to come in from my experience as well, and this is something that's being implemented in Trinity, so I'm sure you should say. And in my experience with other organizations, the issue of this not always being led by a team leader is that it gives the leadership to the whole team. And so when a junior member of staff has an idea that moves on from an idea to innovation, that helps with that innovation sticking. And so from a consistency perspective, we are also present, maybe standing back, we are there just to support in terms of what we need to do need. And also to thank this piece of work and what else can we do. Simply in the service we also have those other books, and it is really a springboard to that sort of innovation, and no idea is a silly idea, and absolutely sometimes it may just be a list of requirements or things that we would like to see, and we can go through those as well. But also it's about how we prioritize those interventions, like so that we've heard and maybe would actually my idea is as your idea, recognizing that we may not be able to everything at the same time, but we can certainly prioritize this based on what we've seen and translate all into. So it does help in some of the junior small practice ideas, and it helps them with their progressions.
Thank you.
Again, on the community side, what was the concerns with surgery? What did you do to address that? Yeah, and early days that came out.
Yeah, so it was mainly around, so the areas for improvement were mainly around incidents. So we had a run of never events, and never events, something that sounds quite scary, but they're things that shouldn't happen. Sessions are in place. Things like doing huddles in surgery and checkpoints, etc. We had a series of never events, and a while before the CQC came in, we had done lots of an external body to review what we were doing, come up with recommendations. We also took out once a month a whole morning of no surgeries, emergency, so stepping it down so all the theatre teams, surgeons and anaesthetists could come together, because you imagine it's really difficult to do that because they're all in their own operating theatres and learning together. So they could see we've made loads of progress and reduced the number of events we were having. It was things like wrong block. It can be everything like the wrong lesion taken off because a number of things happen that not checks and balances. They generally are low or no harm things, but they shouldn't happen if the process is in place. So when they came in, they could see we've made lots of progress in terms of culture in theatres and people. Again, it comes back to culture, being able to challenge if somebody's progressing, being able to put your hand up and say, hang on a minute, we haven't done the pre-surgery checks, or I'm not quite confident about this. So creating that culture where everybody has a voice. And they could see we've made lots of progress, but we hadn't yet embedded some of those changes. So that was the main area. They also found things like environmental hazards. So we were putting beds in front of, there was fire escape being blocked with equipment or beds. So sort of shooting yourself in the foot sort of things. And on the government side, making sure that all risks were captured and documented and then shared learning across the organisation. So something might happen in this area here. How did we learn from that? Make sure we're preempting anything that might happen. They were the areas they particularly felt we needed to address. We've made a lot of progress with this. We do expect them to come back at some point, but and we hope we'll, be able to say that. Those are the sorts of things that they focus.
The trust seen immeasurable improvement in the patient experience. They've been waiting list with the discharge complaints.
So we've
Clinical outcomes.
Yeah, so generally our clinical outcomes are good. Just to say that, I don't want any of this to feel like we don't deliver great clinical care, because in the main we get that right. We have pretty good waiting times for George's. We put a lot of effort at the end of last year to bring our referral to treatment, the 18-week standard, to bring the waits down. We managed to reduce our waiting list. We're meant to have no more than 1% of people waiting over 52 weeks. We brought that down to 0.6%. So we started the year in a much better place, and it's about maintaining that improvement. Our expectation is we should deliver at the end of last year 60% of people being seen within 18 weeks, and we delivered 63%. We're aiming for 67% by the end of the year. So we're on an improvement trajectory. So people are waiting a shorter amount of time. Discharge is improving. We're bringing our length of stay down. We're seeing that palpably come down, but there's still more to go at. And some of that's how we work as a system, not just as an organisation. We're very much leaning into neighbourhoods, neighbourhood working, left shift. We're very active in Wandsworth and Merton around neighbourhood opportunities. So we're in reasonably good shape around in those areas, and we get pretty good patient experience feedback as well. So that's around like even in an emergency department, which I know can be challenging at sometimes around waiting.
Thank you, Chair. Well, a full mark. This is an enormous programme, very challenging. I thought they needed. Leadership development programmes, culture change are notoriously difficult things to do. In my experience, people are going to do what the leaders do, right? So their leaders have to be role models in what they're doing. And my guess is that some of your leaders aren't going to be able to make that. Right? It's inevitable. Some of them will not be able to recognise the need for the culture change and the new ways of thinking and doing things. So there's going to be changes in some senior positions, I'm guessing.
Yeah, there have been already. So there's been quite a lot of change around the executive table. I think there's probably a 50% change over the last year, I would say, around the executive table. So we have had change, some change around the site leadership. But you're spot on, because actually role modelling is absolutely critical. How people behave. You behave as a senior leader in a certain way that's not conducive to the things we talked about, then that absolutely gives permission to your teams to behave in that way as well. So
sorry, because it's such a huge amount of work, are you able to do all this yourselves, or are you bringing in specialists to help you?
Well, we're looking at, we've got quite a small OD team, organisational development team. We're going beyond them to draw in expertise and knowledge from other organisations. We lean into NHS Elect as well, who provide a whole set of expertise and knowledge and capacity. So we're drawing down beyond our own hospital resources or organisational resources to help us with this.
But it is minimal.
Yeah.
The theory that we have and we feel quite strongly about is if you get the right talent, you probably work with the right talent to get the right outcomes. And there's nothing more frustrating than watching management consultants walk in, charge a load of money, things you already knew, then walk out. So it's very nominal, which is why the leadership there's been quite a churn. You're right, it won't end there. I'm sure it won't be for everyone. But a lot of what we're describing, we are doing with our own people. That creates a capacity constraint at the same time. We had a really great leadership session with 50 odd. On Friday, the challenges we've got more than we can ever possibly shake the stick at, and we've got to work together very differently to be able to accommodate that. But we are choosing that in preference to getting an army of third-party contractors.
As a former management consultant, that sounds like a very There's a couple of questions. One of the things in the Ockenden review, which I'm not going to ask you about generally, because it's just come out, was about feedback and listening to what the staff say, because clearly a lot of staff knew about the problems, but they were ignoring listen to. We just wanted to ensure that that's what making sure that those processes work is one of the things I think it is from what you said on your agenda. And the other one is, and again, this is early days, that you mentioned racism, and as you know, Lord Mayor's had a very disturbing report about anti-Semitism. And I don't want you to go into that in detail because, again, it's only recently come out a month or so ago. I just wonder if you can confirm that's something that's on your board's agenda to look at your processes, and in due course, subject to you, Chair, that that's something that you do, that they can come back and tell us what they plan to do. Thank you.
Thank you very much. I just want to know. It's currently thinking about culture change and the leadership to make sure things are improved. We have to teach others how to behave. I do agree with what Charlie did, because if the leader doesn't know how to behave, follow on with the rest of the. But I'm just thinking that there's a lot of things about culture and racism and all that. Are we sort of looking at that more than actually looking at what patients are actually doing for patients? I'm not saying that's not important. That's very important. But you need to know how what other culture is. It's for the patient is and how people choose people culture and how you think. But it seems to me there's a lot about culture, not a lot about patient. Now I know that we need to worry about things like that. Once you got the staff members knowing how to treat people, you've got to now start concentrating on patients as well. But there's a lot of tries to do with various places. But I think we're missing out on other places. I mean, I'm older. I just think that patients also deserve to be looked after or to be remembered and to get the benefit of it, to be getting. When you're talking about, you're saying about the hospital, something CPC, and things were happening, something about removing the wrong lesion and things like that should happen. That should certainly not happen. That should certainly not a minor thing. If you're going in and lesion the wrong one, I'd say that's really dreadful. So yeah, I think we should be concentrating stuff like that. It's very important. Concentrating on the patient as well. But we mustn't just be single-minded of one thing, but we let that side down. We've got to try and bring them together and make sure that we've got things together, not offhand. And because the next thing we do is that we fantastic, but then we're not worried about the patient. So we're sort of running and catching up on ourselves.
No, I just want to reassure you, quality and safety is absolutely top of our agenda still. I think where culture and quality and safety intersect is you have staff who feel engaged with the organisation, feel valued. That does help you deliver better patient care. That's sort of well researched and understood. So I think it has an important part in that, but it's certainly not the only thing that we're working on. And you're absolutely right. It's quality, safety, care and protection for our patients is the top of the agenda.
So this is the voices on this issues. And I'm from the nursing background, midwifery and everything. I'm just thinking that do you have mentoring and monitoring? And how long does that last?
In maternity or both? But certainly from a safety perspective, some is a robust receptorship program. So advise once joining the team after qualifying, we'll have all these up to 1 year. We have a receptorship program for them becoming about 6 months senior midwife. And from a mentoring perspective, we have mentoring, close mentoring, we have coaching. So there's a range of opportunities to be staff both within hospital and within settings.
Sorry, can I just check? Are we looking at cancer screening now or later? Now. So can I ask a question about the cancer screening? So because it's below below the target level, 77% with 62-day standard compared to national standard of 85%.
That's cancer, but that's not cancer screen. Are you looking at screening
Yeah.
specifically, or are you looking
Well,
at 60?
yes, no. So, but cancer screen.
Breast screening.
Yeah,
Yeah.
well, for breast screening, certainly,
Yeah.
there was no bid put in for a mobile site, which I was surprised to see. Can you explain why no bid was put in for that?
I mean, I
The Merton doesn't have a.
No, and I know Peter and I have had regular discussions around sites in the future in Merton, the Wilson, and how that might develop. I think mobile sites are generally not considered the way forward anymore in terms of breast screening. Static sites are what are very much supported and pushed forward by breast screening, NHSC breast screening. So mobile sites generally are not supported anymore.
Okay, but we know that YMCAs are being used in Kingston for cancer screening, Astor in Wallington. But where are we on that?
I don't know if that's breast. I don't
No,
know
that's
breast
lung
screening.
cancer.
No. Lung cancer, yes, yeah.
So what do we have in Merton?
Okay. There are screening in more affluent areas of Merton, which is something that Peter and I talked about a few times. So that we don't have a static screening site in Merton.
Are we getting one?
Well, I don't have an answer for that today. That's something we're working on, but we have to work with the national team because it's about how they fund that to happen.
Okay, I would have thought that would be a priority.
Chair, I think it is a specific item on the work programme that we're coming to later on breast screening to come back to
Come back
to the board. So if the like on the work plans for later.
Okay.
Thank you.
Must have been a few agreement, so we have asked quite a few times, Wilson is debate. I can't understand how they're not for mobile breastfeeding, but therefore we've got something else somewhere and they've got.
That's for breast. It's not
but
necessarily the same for everything.
Well, it's a breast one, so it's a screening, mobile screening machine. But we should be able to use it for all screening, not just the breast. We should have it in Wilson. We've been asking for years and we should get them put back. They're thinking about it. Yes, you can have it. No, you can't. Now the latest thing is that they're not favourable anymore. The application is not.
Well, should we come back to the meeting and we can come back with a range of where we're at, what the issues are? I'm really happy to do it.
Thank you. It's on the agenda.
Yeah.
Thank you.
You come back with something that you really do.
Prepared to talk about it,
You don't want to
absolutely.
do the same thing all
No,
over.
that's right, and I don't have all the information at my fingertips tonight, so I don't.
That's fine, we're just keep marking,
Yeah.
the space of it.
Yes, that's fine, so happy to make that and that. Right, team.
Simon,
Well, just to come back on my question, which,
Oh, did you want me to answer?
well, only to say, could you confirm that you'll let us have
Yes.
the note on what you're going to do about all that?
Absolutely, because both of them are high priority, but absolutely, when they're being discussed at executive level.
Thank you.
Yes.
anybody else before we go on to alternative?
Can I suggest the east via Michelle to talk about St George's alternative and secrecy, because you can get me, so that's been quite an issue for us. Leading, and it's fantastic to have Michelle, and I quite like her. I just tell her credentials with you, and then we can ease into then the St Helier maternity.
Thank you. So I joined the group about 10 weeks ago as the chief delivery officer. And prior to this, I supported East Kent on the improvement journey after the publication of the National Inquiry. So huge amounts of experience in supporting families who've been harmed in care, restorative work, and also leading organisation from inadequate to good. Before that, I worked as a director of another organisation where I supported that service from good to outstanding. So in my sort of skill set, I have experience from across the board leading services within the vicinity. So as I said, when joining St George's 10, 12 weeks ago, I took the opportunity to really review, to listen to staff, to listen to women and families, to pause and to re-engage with the team as a whole, and then reset the direction of travel for St George's particularly. We were able to host a large stakeholder event on the 12th of May, where we revisited. So we weren't starting with zero, because, as you know, the CPC inspection, the last CPC inspection, showed we were inadequate to revise. So still a lot of work to do, but work that had been done. In terms of the must and should do actions, certainly by the time I joined the organisation, 29 of those actions have been completed, and there are 2 actions that remain as standard because to ensure that they are embedded for process staff. So looking at some of our key priorities, and a lot of those I'm going to discuss feeds into what Kate has spoken about as well. Because although maternity service, as we know, is the spotlight, we've seen the Auckland inquiry, we've seen that the similarities in that very sad, tragic case. It's so similar to the Kirkup inquiry, to the Bay inquiry, and in some ways, I guess the question for us is: are we focusing on what Donna Auckland is saying we should focus on? And certainly, since joining in George's, some of the key priorities has been, as Peter said, around culture as well. And certainly, I have observed some very good practice. I've observed some situations that we might deal with slightly differently. And so we've had a review of the culture improvement plan, which we've done collaboratively with staff, but also with families who are currently using the service, and can't stress how important that is, listening to those voices. And off the back of that, we have procured civil society lives training, so that staff will be trained, but we're also very visible in the clinical area, so that we can be listening, we can be attending handovers, we can be listening to others and supporting the staff in that way. And that, in fact, has always been my approach as a senior leader. So we also appointed to the director of the role. Unfortunately, at St George's for the last year, or there's been a redeployment of that director of the role, and we know that has an impact. So we've now appointed a senior midwife as the director of the role, and she's also very visible in clinical practice, supporting the team from that perspective. We also had then focus on health equity, and we know that this has also come out of the most recent Auckland report, but from previous reports as well. And when looking at health equity, we understand that it's quite broad, but it's really important. We know that the COVID pandemic shone a light on disparities in outcomes within services. It's important that we understand the national picture, but it's also important that we know what our local data is telling us. So we've had a huge piece of work looking at our local data and actually stratifying our outcomes by ethnicity, by deprivation. So looking at those women and families who are living in the poorer, so it's IMDs, but also looking at ethnicity and some of the sort of comorbidities that come with that. And what so I reviewed syllabus for last year at St George's, and surprisingly, what we saw in there was that there was quite an involvement. There was a large involvement of women from Black and ethnic groups, but actually a smaller involvement of women from deprived areas. So that doesn't say that there isn't an issue with deprivation, but what it says is that we do need to be focusing on ethnicity and issues, the interplay between ethnicity and poorer outcome. So we are working with our users, because we do know when looking at maternity services, access is really important. We want to have women who access care really early in their pregnancy so that they can go along the correct pathway. We also know that persistent cultures, because of beliefs around miscarriage, etc., that they may choose not to come forward very early. So we are working with our users to have campaigns around things like that. So we, and this hasn't only been for St George's, we've done this as a group. So we worked across the group to look at the 4 top interventions that across the group would meet the biggest impact. And so we landed on, firstly, understanding our data and beginning to stratify those outcomes. So as Peter said, we are looking at developing, and we've now nearly completed with the development of that scorecard by stratifying outcomes by ethnicity and by IMD. And we then looked at being able to provide targeted care. So ensuring that those who need it the most are having that continuity of care. And that's something that has come out of a succession of inquiries as well. The third priority is around antenatal education. So we know what our main languages are in the local communities, the top 5 languages that are women who are non-English speaking, and we're now providing antenatal education in all of these 5 languages, which is fantastic. And finally, going on to the point around ethnicity and some of the other issues that we've been highlighting, the need for development from a workforce perspective. So we have procured training around cultural competency so that staff are aware of different cultural biases and approach to care. And as you know, that has also come out of the inquiry. We've also procured training for staff around human rights and consent, all of which play a really important part in terms of equity. So we're hoping that by developing that approach, where we're really understanding our data, separating resources that needs from signals, and we can actually look at what the gaps are. I think my observation was that there's lots of interventions, but in this way we can understand what the gap is, and then look at what intervention we put in place to narrow those gaps. So that's the approach that we're having from an equity perspective. And of course, last week, that was confirmed in some the findings of the inquiry. We know that tomorrow we'll be having the national aims as well. And as Michael said, I'm on one of the expert reference groups that will be supporting the recommendations moving forward, which is quite valuable as well. So that's around equity. We spoke a bit about clinical pathways that underpin safe care and that interplay with culture. We know that's really important, and just to take up on the question here, but absolutely we must have clinical, we must have pathways that underpin safe care. But we also know that actually if we are deviating from these pathways, or if people have got that psychological safety, that prohibits the implementation of those pathways, and that's why we have to work on getting cultural rights as well. We also know that technical care is not sufficient, and lots of comparison shows the importance of compassion and kindness, and that's where culture also comes into that. So that's where our focus is. Looking at governance and learning, because we work in a group, I was able to implement a group-wide collaborative learning collaborative and peer review process, so that the team at Epsom and Elliot, at St George's, and have fresh eyes of their processes and vice versa. So that's a group-wide sort of peer review process that we've been implementing. Workforce is always important, and ensuring that that we have the right staff with the right skills and competencies, and ensuring that the staff are trained and key issues such as CTG monitoring and all of the care bundles, so CPD science, clinical care bundle, and that remains one of our priorities. And then finally, looking at maternity oversight. So we know that this is one of the key areas of recommendations, again, certainly when joining the team. That has been my focus, so not just at ward level, where we're looking at weekly oversight and reviews of things like safety checks and fresh eyes of CTGs and all of those key safety metrics, but also at board level. And so I was able to introduce a maternity subcommittee to the board, which gives the executive team an ability to really have a detailed oversight into maternity services, and this is across the group. So this is for Epsom and Elliot as well as St George's, and that starts on the 27th of July. That will be our first maternity board, and from there that will be escalated to the trust board and others, and that gives sort of assurance around oversight. So just ensuring as well that we have our reporting is streamlined, because being mindful that there is a lot of reporting, as we know, in terms of maternity. And that we are able again to use our data in such a way so we're tracking our outcomes. So we now have dashboards that use SPC charts so that we can look at things like what is our silver rate, how does that compare to the national averages, what is happening with our neonatal death rates, what is happening with our brain injuries, etc. And also bear in mind St George's, that because of the complexity of NPC at St George's, because of specialist services, so we have specialist services for CRETA and the large BMIs, etc. All of that is factored into sort of, and that gives the board the ability as well to focus on the key areas of practice. So that's been some of the work that we've been doing in the last 8 weeks, and obviously that all feeds into the CQC readiness. So from my perspective, CQC inspection is a snapshot at a time. it's very important to implement all of those must and should do actions. We can't lose sight about all of those 5 doings as well. So looking at, is our care safe? Is it effective? Are we responsive? How are we ensuring that responsiveness? Is it well led? All of these factors come together to enable us to achieve those ratings that we want to see achieved. So that's just a sort of whistle-stop tour of some of the key priorities within maternity. And this is, as I said, both for Epsom and Helier. As we know, Epsom and Helier has recently had their CPC inspection outcome and have been really good, which we're very proud to see that as well, demonstrating from previous inspection. So, and it's safe to say it's about ensuring that we are taking time to celebrate successes as well, because we are, currently within maternity, it's been in the spotlight for many years. Really important that we are working with our staff and wrapping ourselves around them, ensuring that we focus on our well-being so that we can take forward the we're very fortunate at St George's to have good engagement with our users. So we have quite a strong maternity and neonatal voices partnership, which again is reflective of the demographics. So there's lots of work. There's always more to be done, and there is more to be done around ensuring that we are listening and that we're hearing all of the voices. So who's hard to reach.
Thank you.
This spot.
Yeah.
Brilliant. Thank you very much. I'm Sarah. I've been dispatched on the MVP for several years and I'm very well because it's St George's. So I have a lot of questions. I hope that's all right.
So I have one question at a time, Sarah, and then we
That's okay. I'll start with, can you give us an update, please, on the future of the Calm Suite?
Common Suite. So yeah, absolutely, and that has been one of the priorities since we started as well. So prior to me joining the team, there was a review. The view was that there was an underutilization. The Common Suite is the food centre at St George's, and so as part of my review, I was able to review together with Kate the report that had gone forward together with our users, and to really look at the model that is being used. So we know that that what I saw when joining the service was that there was an underutilization of that facility for many reasons. And so we have worked to identify what does that model, what should that model look like, and also if there are safety concerns, how can we mitigate these safety concerns? So we have looked at safe transfer from the common suite is on the 4th floor, the delivery suite is on the 1st floor. So doing drills, for example, so that we can time and that we can communicate with them actually that if there was an obstetric emergency, it will take X number of minutes to get us safely to the neighborhood. We can have grab bags emergency. So we go through that side of it, and we have also worked through with our users what that facility could look like in terms of the model for the workforce being there. So from a perspective, and we will be continuing in the next 12 months reviewing the service.
Yeah, no, thanks, Michelle. I mean, we've agreed with Michelle and Adeline, who's director of the on the site, that we will really focus on how we can make that unit work, be productive and safe. Both Michelle and Adeline feel that there's a real opportunity to make it thrive. It was a number of issues around really low usage, being regularly closed, and also a third of the women who start their birthing experience there, then being moved down 2 floors, which is not ideal, but very confident we can address all of those issues. We can already see, and also it was very much used by white middle class women and no one else. So there's a whole set of things there that you need to address. I'm really confident we've got the live with really live in place, as you can hear and see, to be able to tackle that and to address it in a more positive way going forward. So we sort of look at another 12 months with 9 months check-in and how we're getting on with that, but we're leaving it in Michelle and Adeline's hand to work that.
And so we've already seen an uptick in the utilisation, which is very positive, and we hope to see more. So we've looked at pathways as well, so like a 6-week handover to the team, so that there's continuity, there's information of women that are informed, and that fits into everything that I spoke about in terms of consent and the practices and so on. So yes, so we are very much present there in the centre, which is much needed.
Thank you. Brilliant. Thank you. Can I go in?
Yeah, sure.
I'm really pleased to listen to what you say, because I'm an excellent woman. Very transparent. has really done helpful in COVID. Because of ammunition. Where in fact most people, especially technical, you get isolated. And you need to have that to begin with, in order to start. And so I'm glad that you're working on it, but I really want to know if see that we just arrived, is working very well, doing everything, and I'm going to be racist. It's nice to see that there is somebody of color, especially with this nation, in segregation. That doesn't work. We create a lot of problem. So I'm just wondering, are you doing data and checking to see or how slowly you're going instead of capacity of what you're doing?
Oh, absolutely, yes. So that's the key priority, and actually using the East End experience. It is so important to have a visa so that we can, and it all has to be outcomes based so that we can actually look at. And one of the things that we're doing to keep the pace is we've just had a project be approved so that we can keep oversight of all of the projects because there are many, and that I can have that sort of oversight from a clinical perspective, but then from a more administrative project management type of perspective that is being continued. And sometimes it's important to have someone who is non-clinical and they're not pulled into clinical practice, so they can continue with that, and that would be extremely helpful. And that's certainly been my experience in the past, where there are multiple projects to be undertaken simultaneously. So that's how we would maintain the pace around, and we would track.
Thank you, and thank you for updating the afternoon. I've got two follow-up questions. First, have you done any assessment on the impact on health inequalities if the machine activity is moved away from some area? And you mentioned the languages and characteristics. Can I specifically for Eastern European Commission?
Yeah.
Are they included?
So we have a Polish midwife who's Polish facilities with the Polish countries.
So one of those 5 languages is not.
Yeah.
So
And
it's just
an impact assessment will be done for any sort of changes. So currently we are looking at, as I said, we're looking at deprivation and we're looking at outcomes of ethnicity. But any sort of changes to the systems will require full impact assessment, and that will be done.
So can I just clarify? Will the Eastern European be moved to the characteristic, or they still be part of whatever?
Move to where, sorry?
The Eastern European communities, they are currently under white or the group.
Yeah.
So are they becoming the characteristic in the measured data? Or,
yeah, so yes, that's an interesting question from a national perspective. Eastern European women would be considered white other, but actually when we're looking at things like access, language is incorporated from that perspective, because language could be a key barrier. And there are also some cultural nuances that we need to consider. So.
yeah.
I was concerned about governments and in terms of who they go to, which hospital to choose to go to. And we have middle class people and they well, they go to St George's. It sounds, but it sounds to me that some will go to Kingston. So what's the difference between Kingston? It's early days.
Yeah, so it is. I think for maternity across the board, women tend to go to their feet and reputation. CQC infection rates tend to be one of the factors. That definitely is. And I know from my previous experience where we had an outstanding rate, and within sort of 6 months, we saw an increase in the birth rate, and that's something that we will do. So when you're planning to services, you have to consider things like that as well.
I didn't question.
It's very interesting.
Yeah, that's the students. Yes.
Yeah, and I think for women and families who, and I'm just thinking of my previous experience at East Kent as well. You know, it's not a reality for someone to travel to. The choice is there, but it may not be a reality for them, depending on social etc. And so we need to be really intentional in that space to ensure women feel heard and that they are aware of all that we're doing, so that they're not afraid of coming to places. And that's something that we can work on around.
It from ask what the state structural or engineering advice the trust received about the safety of some public maternity facilities and will this be shared with us?
It might help if I do a bit of context about St Helier. Is that all right? If questions of George's and we celebrate, maybe come back to George's in a second. But so just do a bit of context because it might address some other questions as well. Just to take your one. And Cheryl was alluding to the fact that CDC rating for St Helier is very good. So the decision around E-block is all the more galling for a start. Just so everyone's got a shared awareness of feasibility if you're left to, hopefully we've got the reply to you today, but yeah, it's a big deal for us. Obviously, we don't reach conclusions like this lightly. I've just spent this morning with your 60 midwives and consultants who have similar questions to your one, which I will come back to. In late 2024, we had some concerning readings of water around bacteria, particularly pseudomonas at the time. And lastly, readings around Legionella at a worrying count level. It's not unusual to manage bacteria levels, but actually the worrying count level they respond. We have at the time, and this is early spring 2025, we brought in 2 independent specialists advice. Do how to manage it, what was the long-term solution. And to your direct question, yes, we will be in a position to share that advice. Staff have asked exactly the same thing. The mitigations to make the water safe in E-block, and E-block covers maternity, neonatology, gynecology, assisted conception, amongst others, are in place. And so it's really important that people hear the message that the services are absolutely safe. And because we've implemented the mitigations that they described, and that's fine. What importantly, though, they have advised us is it's not a long-term solution. They're doing a short-term solution, and the long-term solution is to completely replace the piping water for that building. This building is, you know, St Helier, you know, if you lean on it, probably fall over. It's very old. I bought a house recently of a similar age, and I can't find the pipes either. It's very difficult to assess a building like that. A lot of work's happened over the years. Not all of that's been recorded. There's very high likelihood of asbestos in the building, and so to replace the water system is hugely disruptive. The board's advice and its current understanding is we can't replace the water system and allow services to continue in that building at the same time. So the priority at the moment is to understand whether and to what extent we can decant those services onto St Helier site whilst that work is done. That's really substantial work, and obviously it's a combination of outpatient and inpatient services. That's what we're working through at the moment. We have said that we really need to be able to start the work and come out of the building certainly in spring of 2027. April. That doesn't allow us much time. Yet. And the teams are really saddened by this. St Helier is a very aged estate. So I don't think there's huge surprise about some of the challenges, but the teams have tolerated a lot for a long time. They love their service, and quite rightly they should be very proud of it. So we're assessing options at the moment about where can we accommodate these services on the St Helier site? What are the conditions necessary for that to be feasible? That is priority currently. We are due to update the board on the 9th of July as our options appraisal. It's very likely that we are going to be only be able to share the options which are feasible and the options that we don't think are feasible in order for us to take a further step. Priorities for this side at this stage. Obviously, just taking a step back, the challenges I'm describing for that building could also be challenges elsewhere in the estate. Now, we monitor our water. We do not have the same levels of count in other parts of the estate, so we are satisfied with that. We are continuing to enhance monitoring, but it's a matter of time, really, before we have challenges like this elsewhere in the estate. So this is really challenging for us. You'll all know, many of you I'm sure have been supporting this council longer than I've been around, but we have a large capital case agreed for the Sutton Hospital. That was put back to starting work in 2033 with opening of view in 2038. Frankly, St Helier can't wait that long. Now, we have the new hospitals programme visiting us for the day next week. We are doing a series of visits with them throughout the day. Matt and myself will take them around in good. And we are asking them, and we'll be talking to them about these challenges, about how can we bring some of that. Because really, if we're gonna combine energy on anything, it should be about getting energy towards bringing that capital forward, because St Helier hasn't got time. Now, interestingly, being helpfully shared the historical information by the comms team in January 2025, we did put out a statement that said St Helier can't wait that long, and we are going to struggle to manage services safely. And what I'm explaining to you today is a good example of that challenge. So we will absolutely share more with you once we know more. We've been able to appraise the options and then. Okay. I think that was a really long answer to your question, but
very good experience in something clear.
many do. Yeah, many do.
No, you just said that you. So I can ask the question that maybe considers for people maternity service offering safely at St Helier would be urgent repair the temporary works. It seems that you got that in mind. Simply, urgent repairs. What you said,
Yeah.
to be urgent repair. And you talk about trains work in terms of space on the side or.
That's what the estates team are.
Even on the opposite side.
Well, that's St Helier at the moment is the focus. What can we accommodate on St Helier side? And bearing in mind, the maternity pathway is a long pathway, right? There's lots of visits. The delivery is one part of a very long pathway. So there's a big difference between inpatient and outpatient. And we want to be able to continue to provide services where people are used to accessing as far as we possibly can. Priority is to assess that something. That's not an easy ask, inevitably. But we need to understand service by service, where might it go, what will it take? You have to remember though, this is against a backdrop of a safety decision. So those options need to fit in with our ability to manage the safety for people. So we are wanting to do this in a planned way, and it feels like coming to April, it's going to feel planned, but still quite really stretching, to avoid us having to decant in a very unplanned way. We were to have an outbreak or clinical infection start, then we've got an unplanned decant to work about. That's what we're trying to avoid. To bring it to life, in case my description hasn't already, you have to give this back, by the way. We have got an example of the pipework that comes out in cross section. The water that feeds the radiators is also used for washing people's hands. And this is an example, cross section of the pipe that comes out that needs to be replaced. And when we have met with a couple of MPs recently when we shared this with them, I've only got one, so you must give it back, but very happy to just for people's sake, because it just brings to life the challenge that we've got. And so when you say urgent repairs, yes, urgent and absolutely necessary.
So talking about the camping, which section are you leaving camping, not decamping? where you think you'll be capping to.
So we're going to take one decision at a time. At the moment, the estates teams and specialists are working through what are the options available to us on the St Helier site so we keep the services as local as possible. So that might mean moving other things around. It may mean extending some of our capacity on that side. They will advise us, the board, by the 9th of July as to what their options appraisal looks like. They'll be able to say these options are not viable in our view, these options are. So there won't be firm decisions in that. There won't be a firm option that says yes, we can land that. I doubt very much, maybe for one or two, but that gives us a short list. I've said to staff, it's going to be very open with them, the short list that comes out of that process for us to take another step forward. And who else we need to work with taking.
And there's just it's done.
At the moment, if we can focus on the St Helier side, then that makes that a lot easier. The ability to accommodate everything on St Helier side is going to be a stretching ask in the time that we've got allowed to us. In the event that we may need to rely on support from others, then we'd anticipate that our midwives will go support those services. The births still need to be looked up. So I've had that direct question from staff. I can't guarantee that all of their jobs will be in the same place in the future. I can't guarantee that I can give them a further redeployment opportunity as close to their homes as they might have one today. So I can't go that far, but we will absolutely fight to make sure there's nobody. Nobody wants to start losing big ones when we've got, maternity women to look after. Exactly. But I have to be careful not to give guarantees I can't see through. But we want to take it one step at a time. And the first step is, can we accommodate this?
I get the feeling that kind of community using like them elsewhere. But there's always been a thing about moving to Georgia or something. It is my opportunity to do that.
That is not our plan. You have got the backdrop though of the Setch case, to my point earlier about what we needed that money to come forward faster. And in the Setch, the Sutton Hospital case, it did consolidate maternity services earlier onto something. And the facts do speak for themselves. We have had a declining birth rate. They are relatively small maternity services. But that's not our route to get there. What we're worried about is the safety of the system and how long we can rely on it for and the hallucination. This illuminates for me the absolute necessity to see through the capital investment required for this part. Billy.
Yeah, well, if the world blows up,
Thank you for looking after it.
if the world blows up, we can't, we have to deal with the outcome of the explosion, to use a metaphor. So that, obviously that's of concern. But the big concern, I suppose, unspoken concern, once you move maternity away from St Helier, it ain't coming back. Now you may say, well, I've heard the word in previous life, it's a temporary measure and it comes rest of first. We said something interesting on when it goes to the board. And I'd be interested to see how we can test the board position. You said we'll take the options to the board, right? And we'll give it the viable, right? Now that's a kind of semi-political decision in terms of what you think, your board thinks is viable, and what we may think is viable.
Yeah.
So it's we can all, we can all do that over all aspects of our life. So where is the point, particularly because then also it's about engaging the communities, the MPs, and etc. Where is the point where we can test your judgment on? Because you'll come to a decision So, well, they're not viable, but we may say, if you like, representatives of the member of the public, we think it is viable. So what's the exact date? And how is that exposed, not in a scandalous way, but how is that tested against other people who may come to a different conclusion?
So it's a great question. I had a similar question with the start this morning.
All right.
I'd be happy to share both.
Right, okay.
And as far as we can, the data behind both that rationale, and the board may have a different view to what we vote, right, too. If we find ourselves in a situation whereby we really need some partners' help to get through the current period, then all partners, whoever they are, local authorities or other hospitals, are going to want to know the same answer to that question. So we will be ready for that.
So you're going to share, if you like, the alternative, the options that you ruled out.
Yeah.
They will be shared.
We'll be open about that, yes.
So with the data and everything.
We'll be open about that, yeah.
Okay, I think I've got you.
I think you have to remember the backdrop to this is a safety consideration which the board is carrying. We are on the hook for health and safety for the people that in that building, who use that building, patients, babies, staff. And the board will have to know under kind of what's viable within the risk tolerance we're willing to manage.
Yeah, can I just ask you one more question on the timeline story? Where does the timeline come from? I hate to say, but I wasn't quite sure what. I mean, this is you see, it's showing us the pipe, right? Where is the driver? It says this is all going to blow up by.
Yeah, well, it's not a linear. It doesn't get worse every month.
Yeah.
If it did, at least we knew we'd have a more accurate detonator point. But the mitigations which are short term, we have a sense from the independent advice how short term tends to mean. And then you've got other compounding factors. I have to mention last week's heat wave does not help water management. The filters on the taps slow the flow of water, combined with a heat wave, not great, right?
So can you suggest, if that's the case, can you share that with?
I've already said that we'd be open about the independent prices.
All right. Is that possible?
Yeah.
Share.
I'm not going to give you a report that says it's going to blow up in May. In April. It's not going to be quite like that.
No, yeah, I get that, but if there's something heading towards us, I'd like to know how far the meteor is. Okay, thank you. All right.
Sarah. Thank you. I'd like to come back a little bit to St George's, if I may, it's still relevant. I forgot to comment on my previous question, but Michelle, you and Adeline's recognition have proceeded, and I was very happy to see you. Oh, thank you. So I started feeling very positive about the potential changes that you were going to make. But my actual question was about your improvements to reporting data, including the dashboard. So several years ago, both St George's and St Helier stopped publishing monthly data updates for the general public, which they previously been doing on social media regularly. And they're not going very well with local women and people for sure. And Councillor Claymore earlier as well was asking about how people choose which offer to do. So are there plans to start republishing this information to enable women and wealthy people to make informed choices about breast seed, especially in the light of the potential changes?
Absolutely. So we've been working on a patient-led scorecard, which is what we've done in my previous experience. There is a challenge at St George's around the IT system. So currently we're working through that. We met last week with the director of IT to be sure that the data that we're collecting is robust. And once we have that, we will absolutely be able to work with the MNVP to look at how that is represented to the public. And there's no reason why that shouldn't be shared.
So the data is not currently available?
Yeah, it is, but we're doing a manual check on a monthly basis. So what I'm saying is that we're working through mandating certain fields so that we don't have to just laboriously scroll through the data, because that's one of the challenges of the current system. But we can absolutely start working with our MNVP at looking at what that scorecard is that we can share. Because in my experience, that's what people always like. Go into social media and it includes all of the key sorts of metrics.
I understand, is there any kind of timeline for this?
Yeah, so I'll take it back to the MNVP because usually it has to be the language that lands with women. And as soon as they're able to work through that, then I can come back to you with an actual time. It's not something that should take many months to do. It's just around the format. Because we can hear things like the number of births, number of girls and boys, and the heaviest baby and all of birth and all of the things that to that.
Unless it's for us.
Yeah, and FFT, well, things like friends and family tests, all of those things that people can see. Cesarean section rates and things like that.
This is just mainly my anyway, my head running away with me because when you're talking about and then I started thinking of babies who was susceptible to anything. And also with mothers, they're not all just ordinary delivery. It could be severe, it could be also. And so I'm just wondering, have we got any plans to try and mitigate that?
So we're testing, we do testing currently, so to ensure that there is no infections, and we haven't had any infections reported, so that's absolutely part of the mitigation. Looking at infection rates and testing, and the water testing as well.
Yeah.
That's the one on the water on the tax. You said it was being built, so it's great. But it's obviously have you got any to give patients to drink, to wash and so on, and surgery there? You have to put it in a bowl. You have to put how you.
No, I mean, I'm simplifying for effect. I'm going to specialist trust me. But yeah, so we've had a full range of recommendations and suggestions to follow. So we are not having to do workarounds. Which is so.
The quantity is there.
Yes.
Thank you.
So,
sorry, I can't see my other thing. So Tom says that they're having a project where they've been working on a specific dedicated help. I'm sure you're familiar with it. Yes, I don't know if anything like that in St George's in terms of improving outcomes specifically for that.
yeah. So it's a very interesting question, because in my previous role, we looked at something like this for Black women, and the feedback we had from Black women was, why do we need to have this? This is segregation. Why do you need to be according to the color of my skin? So I think we have to be really mindful of anything that just also puts women into one basket. And so any initiatives that we take in at St George's or St Helier will be with our users involved. And absolutely our priority is looking, as I said, on health equities and access and all of those issues. But any sort of system that could appear to be segregated is something we just need to be really mindful of. What I'm saying is that we are working with our users to listen, having those aspects, having that those low thresholds for responding. Essentially, it's one of the projects that we're looking to sketch so that we can have a outline. Some heavier and but not in the same format as the GST.
Thank you.
In the work of it, you're doing, you can separate,
Yeah.
they think everybody should get the same
Absolutely.
thing.
Yeah,
You
absolutely.
should judge people for what they are. They should know that, the level of pain threshold. You said that because they're Black sheep of higher threshold.
Yeah.
So I think we start treating things like that because they're a little too late. You have to find different ways. Anybody else? Simon.
Thank you, Chair. A couple of points. First of all, I think it was very welcome to hear your point about the important thing of just getting which is obviously been delayed for all sorts of reasons. I don't know whether you saw the letter to the Minister today from the local MPs,
Yeah.
the Sutton Council. That's one of the points they made in their letter. So that's really welcome to hear. it may be too early, but do you have any sense of how long the work will take to redo the pipework? So how long, you know, if you can, so obviously move the services on site, and that's ideal. But how long the change would be while the work is being done on the pipework?
Only roughly, because as I alluded to earlier, the understanding of the work that's been done over the last 90 years, highly likely includes asbestos, means that the work, we will know more once we start the work. But we are anticipating at least 2 years.
Okay, thank you.
No, I think so.
I just want you to say, one of the difficulties with this map is that we have been involved in fighting acute services, the emergency, and something else. 30 years. Why don't we find someone who recognize that serves people to experiencing on a daily basis helping each other? And it's all very important. People judge you by actually what you're doing. And those and needs some so earlier is insanity. We can't those people to be actually explaining Belmont. And we know that we communities benefit most. From the side, the area and stage every market into this was what amount the definition what's called about diversity. Here's the big slides. What was it that they set up the original things you English the context? It was wherever it was some alien studies, which was complicated. Songs, and we shouldn't. Sometimes people make decisions about it. So we will continue that what we hear is something adventure and well, excuse me, to ask some what necessary something is this council has been all those years, over to change up its family interests. And there are also issues to pray those people in the east, south, building. So we will be in the instead of others. So yeah, and we want to work to work in partnership and partnership. But there has been 100 events that have taken place during that time. Just walking parts, taking us to that. And in that you're supplying then 200 until the emperor one day after it's not in it, so it's some Yeah. And your time. There was this desire to hang on to this fantasy. This really shoots, but I was honest and so always want to stay.
I hear that. Thank you very much. I guess at the heart of this, to your point, is how you serve people. And when I arrived, my team presented me with 7 things that have tried to save Epsom Heather in the last 20 years, and here we are. And so collectively, we've got to do better than the last 20 years. Whatever that might mean by way of outcome, what we're dealing with now, evil, is not in the interest of anyone. Okay.
Do you mind telling us where you, a little bit about yourself, because we're getting straight into it.
I don't have the accolades.
You don't need that.
Thank you. So I've been, I was on loan to St George's a year ago. I applied for the job because I enjoyed it that much. And felt that we were under punching our weight across these hospitals. But my background, I've not been there just that long, but I spent 9 years with Barts Health in North East London. And that at the time was the biggest integration merger at the time. It was really difficult. A lot of lessons learned. It's a lot better now. And I love doing that. So I think there is power from organisations coming together to deal with their most difficult questions. So I'm motivated to support. And I've really enjoyed it. It's been great to have Michelle with us. Lovely to join Kate, who's a long-standing book member.
Yeah. Fulfill some duties to get your information.
Yeah.
And you will be through. So when you come, don't get upset and you that's what I think.
I think we've really enjoyed it actually.
You know, come and have a mile.
Going back in September.
I'll send someone else.
A number of the answers questions today because things haven't progressed where
Well,
you were, where,
yeah, I mean, obviously, we're going to be in touch a lot earlier than that. From what we talked about today on the excellence maternity side. So, but yes, in terms of forward services.
You can actually get some information before you update before you. We're not straight away.
Yeah. It does help to know the areas of interest. Yeah, that'd be helpful.
Right, we finish one now. I don't know. Sure.
Okay.
Thanks very much. Thank you.
Are we all happy with it? Next month?
Yeah.
Something to tell you.
Yeah.
Okay, we all agree?
Yeah. Agreed.
Okay, then. Thank you very much.
Richard's happy.
It's happy.